Okay, so in the next few minutes, I'm just going to give you our hospital's data very quickly, so we have more time for our speakers. So we really indeed in a new era of acute stroke. So we are changing basically from time-based to physiology-based stroke care. So that's what. So this number 3, 4.5, 6, 8, 16, 24, these are super lotto number for next week. Okay, sorry. So as you know, all the data kept coming. First 3 hours was TPA. We added to 4.5 hours. Then let's say, can we, IV TPA is not enough for all the large vessel occlusion, so can we do more? So thrombectomy came in up to 6 hours, 8 hours, 16 hours, and 24 hours. So it's kept changing. So these are our data. As you can see, in 2018, total number was 1,082, out of which 721 acute stroke, 175 hemorrhage, and 186 TIA. This year, for 2 quarters, we have a total 511, with 325 stroke, 106 hemorrhage, and 80 TIA. This is our stroke alert data. So in 2017, we had a 983, which jumped to 1,409, and this year 723 for 2 quarters. The reason for 2018 jump is when the new data came out that you can select the patient all the way up to 24 hours. So we change our criteria on the stroke alert. So the next, if you look at it, percentage of stroke alert with a diagnosis of acute ischemic stroke, ICH or subarachnoid. So at the time of discharge, how many of the stroke alert patients had this diagnosis? So in 2017, 33%, 2018, 30%, and this year for 2 quarters, 38%. Out of that, if you look at percentage of acute ischemic stroke treated with TPA or thrombectomy, 40% in 17, 46% in 2018, and 40% this year. Sometimes I'm asked why we are having so many stroke alert. Are we overdoing it? So if you really look at it, the whole goal is that any patient who comes to the ER with a stroke symptom, we want to make sure that we identify and treat them very quickly. So unlike cardiology, we don't have an EKG. So that's why any patient with stroke symptom, we are doing that. And so this is compared to national data, we are doing a very good job. This is our subarachnoid hemorrhage data, 42 in 17, 54 in 18, and 38 for 2 quarters. Out of which 19 coiling in 17 with 3 clippings, 2 clippings last year, 35 coiling, and this year 20. This is our thrombectomy treatment data. And so IV TPA only, last year were 92, this year for half year 50. Thrombectomy plus TPA, 44 last year and 12 for this year. Total IV last year 127, this year 62. Thrombectomy only 47 last year and 24 this year. So total thrombectomy 91 last year and 36. So IV TPA treatment rate is 19% this year, 17.6. This is really excellent when you think about before, if you go back 2008, less than 2% of all the stroke patients were getting TPA, those who were eligible. And IV TPA combined is 26%, and CST benchmark is other CST is 24. So we are doing a good job that way. So this is thrombectomy door to first pass. So when patients come to emergency room, how soon they are on the angio table and getting their treatment initiated. So this is where new goal is 50%. So all CSC and us struggling to meet that goal, mainly because the process is how to evaluate patient, when family is there, consent, IR team, all those issues really is a reason for delay. Our hemorrhagic transformation rate is excellent. Rate is 5% for 18, our hospital, and CSC is 5.5. This is our long-term follow-up. So modified Rankin scale is what we use to see how they are doing well. So 2 and less is better. So at the discharge, we have 42% has MRS of 42%. At 90 days, it improves to 72%, and 6 months, 83%, and then it plateaus out to 1 year. This is important to remember is that when patients are treated acutely, initially patient or family and nurses don't see that the patients are getting better. What we have to tell them that we are priming the brain for repair. So they have to think about that once they are discharged with the time, therapy, medicine, they will get better. These are, once again, these are data. So that is my just basic slide.